Hello, Rob, the editor of the Biomedical Scientist magazine here. Welcome to the latest instalment of the IBMS Chat podcast. Each episode is based on the Twitter Spaces chats that take place on the first Wednesday of every month. And in this episode we discuss addiction awareness, and I'm joined by the toxicology experts Azuma Kalu, Edmund and Mohammad Kanu. I hope you enjoy the episode, and remember that this can be used for your CPD.
Okay, hi everyone. We'll get the space started. Can you all hear me okay?
Yep, I certainly can.
Great. So I'm Aisha from the IBMS. Thank you for joining our space this month. Today our IBMS chat will take a look at addiction awareness, with Addiction Awareness Week coming up soon in October. We'll be hearing from experts in toxicology from a lab in Sheffield, Azuma, Edmund and Mohammad, as well as Rob from the Biomedical Scientists, on current issues related to drug use and dependence. Azuma is a Chartered Fellow of the IBMS and Lab Manager for Specialised Clinical Chemistry and Toxicology. Edmund is a Consultant Clinical Scientist working mainly in Specialised Clinical Chemistry at Sheffield Teaching Hospitals, and Mohammad is a Senior Biomedical Scientist also at the same hospital. Before I pass you on to Rob, we've got a few simple housekeeping points to keep in mind. So the space is public, meaning that anyone can listen. The session will be recorded, so those who can't attend now can catch up later. If you want to speak, you can click request at the bottom left-hand corner of the screen. And you can also take part by tweeting us a reply and using the IBMS chat hashtag. So I'm going to pass you over to Rob now.
Hello, I hope you can all hear me okay. Thank you so much for coming along tonight. It's really appreciated. Special thanks to Azuma, Edmund and Mohammad for taking their time out to chat to us about addiction and toxicology. As Aisha said at the top there, we would like this to be kind of an interactive forum. So if there's anything you want to say, then you can either request to put your mic on and you can say it, or you can leave a message on here and send us a tweet on the IBMS with the IBMS chat hashtag. But yeah, please do join in, because we want this to be as interactive as possible, and it's for you guys. So if you've got any questions you want to ask, then please do. Right, let's get started. I suppose, first off, thanks again to Azuma, Edmund and Mohammad. It makes sense to start off by just kind of getting to know each other a little bit. So maybe Azuma, if you could unmute yourself and tell us just a little bit about your kind of background and how you came into toxicology.
Right. Good evening. Hi, everybody. My name is Azuma Kalu. I am a Chartered Fellow of the Institute of Biomedical Science. I'm currently the Laboratory Manager of Specialized Clinical Chemistry and Toxicology. So I work with a fantastic team of scientists and clinicians, and we provide, I think, I should say, one of the best toxicology services in the country. My journey in toxicology actually started around 2007. I worked in down south in London. I worked what used to be the old National Poisons Unit, which got moved to Guy's and St. Thomas Hospital. And that's where my love for toxicology started. And I moved up to Sheffield about 2 years ago. And I've been working with a very great team, running a very great toxicology service. And I'm glad that today we have the opportunity, with two of my colleagues to be sharing with you, something we're very passionate about. So I think I'll just yield the microphone so that others can talk.
Brilliant. Mohammad, do you want to tell us just briefly about your passage into toxicology and how you came into the career?
Hi, good evening, everybody. Can you hear me okay?
Yep, perfectly.
All right, yeah. Hi. It's been a pleasure to attend this CPD event organized by IBMS. Hi, my name is Mohammad Kanu, and I'm a senior biomedical scientist in toxicology department at Sheffield Teaching Hospital. My career started as a registered biomedical scientist in clinical chemistry, but then I started enjoying the manual assays, especially in chromatography and HPLC, and I ended up in toxicology, which is a great place to work. and it's very interesting work, like kind of investigation of drugs and their metabolites, interpreting very complex results. And we have a great team of consultant toxicologists whom we keep learning every day. So yeah, it's nice to attend this event.
Oh, brilliant. And finally, Edmund.
So yeah, I'm Ed. I'm a consultant clinical scientist. So I actually went to university in Sheffield, and towards the end of my university time, I decided to try and become a clinical scientist. So I joined the training scheme, and I became a trainee in the labs in Sheffield. But initially, that was general biochemistry. But Sheffield has a very strong reputation for toxicology. It's had a toxicology lab for a long time, and towards the end of my training, I was fortunate enough to have the opportunity to start training more specifically in toxicology. And since then, I've not really looked back. I've just continued to kind of progress in the toxicology unit in Sheffield, and I spend most of my time now writing interpretations and reports on drugs and their metabolites for the coroner, or for clinicians who maybe have got a patient with some form of substance misuse issue. And I particularly enjoy also working out how we're going to detect some of the weird and wonderful drugs that come through our doors. And I spend quite a lot of time working with people like Mohammad, developing methods that we can use to detect the ever-changing array of drugs and compounds that people are using or being exposed to.
Brilliant. Thank you so much, Ed. And to open up with quite a broad question to kick things off, and this is to any of the three speakers, we're here to talk about addiction awareness and toxicology. What exactly is drug addiction? Is it a purely physical thing? Are there psychological elements? How would you characterize it as a concept? I'll put that to Azuma, if I may.
Okay, thank you very much.
Sorry to put you on the spot, Azuma.
It's all right. Drug addiction, is generally considered, to be a brain disorder, and it's defined as a chronic, compulsive and relapsing substance abuse disorder, and it is characterized by, sort of the individual compulsively, seeking after drugs and using these drugs, despite, the negative and adverse consequences. And, being a brain disorder, you would expect that it affects, the functional, sort of aspects of the brain, and it sort of changes, the way the brain, functions, in that, as we know that certain aspects of the brain that are involved in, in rewards, in pleasure, in stress control, as well as self-control. These changes, that affect those areas, not only will affect, this individual's, physiology, but also their psychology, the way they perceive themselves, in their environment. So this, to me, is what drug addiction is.
And can people be predisposed to drug addiction, Azuma, or is it just is everyone starting from the same baseline, as it were?
Well, research has shown that there are a number of risk factors that, could contribute, to, people going on to, becoming drug addicts. There are certain biological, risk factors as well as environmental. So some of those biological, risk factors that have been identified, is, generally, we know that, addictive drugs, they're sort of, produce sort of a pleasurable surge on a particular neurotransmitter that's called, dopamine in a region of the brain. And that's like the, in a region that's called the basal ganglia. this dopamine, it sort of it works, on a particular, neurotransmitter, and the particular one that's called D2. So research has shown that individuals with low D2 receptors are particularly vulnerable, to addictive behaviors.
Mhm.
And this was confirmed, or this has been confirmed, through PET scans. That's what's called positron emission tomography, scan, in which it gives you sort of the 3D image of the brain in so much details, and they've been able to look at these D2 receptors, and their research has shown that individuals, particularly with low D2 receptors, are prone to being at higher risk of developing addiction in life. Another biological component or risk factor that has been identified and also based on research is that identical twins, monozygotic twins, they tend to have similar addiction rates compared to dizygotic twins, that's non-identical twins.
Mhm.
And also, another, biological sort of, knowledge that we have based on research is that um, children that are adopted, tend to have similar, addiction rate, to their biological parents, than their adopted parents. So that tells you that there is a biological connection. Now, the second one is environmental. And this is really, more to do with environmental modeling, because research has shown that children that grew up in environment and families that sort of have got drug addicts as parents, that they tend to grow up in life becoming drug addicts. Showing that somehow their bodies become modeled to tend to become addicts, as a result of, their environment. Another, environmental evidence, which is that, peer pressure, generally, especially with teenagers, they go to parties, their friends nudge them, to, take drugs, and then they try these drugs. Sometimes these children may have grown up in families that, they were taught, that taking drugs is not, good, and then they find themselves in these parties, and then they take these drugs, and then after they've had the effect of those drugs have waned and they've come back to ground zero, they then begin to rationalize, their actions. And it is that process of justifying that action that tend to now model many of these children, many of these teenagers to begin to appreciate, taking drugs. And then you then find them into going on that path and, becoming addicted, to drugs. Because like we know, there are some drugs that are particularly addictive. So for me, these two main components, the biological as well as the environmental, risk factors, they contribute, to drug
Mm.
addiction.
Brilliant. That's a really brilliant answer there, Azuma. And maybe to bring in Ed or Mohammed here, if either of you want to join in. I mean, what are the effects of this on kind of the individual and society? I mean, we know drug addiction is bad, but what is drug addiction actually doing?
I was just wondering, Rob, what people on the call think about people who are addicted to a particular substance, because I think we're moving more also towards a view that drug addiction is a disease.
Mm-hmm.
So perhaps in the past we've thought of it maybe as something that it's somebody's fault that they've taken a compound and they've become addicted to it, and that they need to kind of sort themselves out and become not addicted to that compound or that drug. And I think more and more we're moving towards the realization that no matter how somebody becomes addicted to a compound or a drug, and no matter how they have whether they have a predefined increased risk of becoming addicted to a compound, whether that be a biological risk or an environmental risk. Once somebody is addicted, I think treating it as a disease is more of where we're moving to than treating it as, you know, somebody's fault or somebody's somebody's own place to try and resolve. And that's where we have addiction services and treatment services and things like that. I don't know how, you know, people on the call would feel about seeing somebody, you know, who had when they walk down the high street and they see somebody who's been taking spice or whatever, acting in a strange way. I don't know what people's initial reaction would be, whether that would be, oh, you know, is this all their fault? Or, you know, should we be treating these people in the same way that we would treat somebody with cancer or somebody with another disease? That's quite an interesting concept, I think. And I think there's more and more people now who are recognizing that treating it as a disease is more helpful, I think, than kind of stigmatizing people. But I think those stigmas still exist in society. And that's obviously because it has addiction and substance misuse has a very detrimental effect on society in general.
Yeah, no, it is incredible how kind of societal perceptions are moving on. And just while we're waiting to see if there are any responses to that open question you put out there, we've had one response come back from I'm Cultured, which says, how much of a part does the lab play in monitoring the recovery of people living with addiction? And are there any local policies and guidelines that emphasise multidisciplinary, including laboratory?
Yeah, sorry, yeah. I think it just broke up very briefly, but I think I got the nub of the question. So absolutely, the lab is involved in supporting clinicians who are treating people with addiction. And that would primarily really be people who have got quite serious addictions to things like heroin or cocaine, illicit substances. But more and more, I think we're seeing that substance misuse services are being drawn into supporting people who you may not expect to be suffering from addiction, people who have become hooked on painkillers and things like that, people who drink too much alcohol. And so as a laboratory, what we would do primarily in supporting those services is in providing testing. So to make sure that, first of all, to find out what these people may or may not be taking, because they may not necessarily be taking the thing that they think they're taking. So we can help in that regard in kind of pinning down exactly what it is that somebody might be taking and might be addicted to. And then monitoring those individuals as they're treated, as they're given different therapies and substitution therapies, to see if they're able to reduce their use or to stop their use of a particular substance over time. And I think there's varying degrees of success. I think there's some very heartwarming and wonderful stories about people who have really managed to turn around their lives with the support of addiction services. There's equally massive challenges and people who really struggle to kind of deal with an addiction. But there are support services there. They're obviously, as is everything with kind of health and social care at the moment, really in the UK, the services are perhaps not as extensive as the need is, but there are services there for people to access if they need them.
Are these services underfunded at all, Ed, because of kind of previously held prejudices about people with drug addiction with drug addiction issues, and maybe the idea that might be propagated by certain elements of the press that, you know, why should we give our money to curing these people with drug addictions when we've got other issues such as cancer to deal with?
That's an interesting question. I don't know that. So I would certainly say that the services are underfunded, but you could say that about pretty much any service, I think, that's funded by health and social care at the moment. So primarily these services wouldn't be funded via the NHS. They'd be funded via local councils and health and social care. And so you could say the same thing about caring for the elderly, couldn't you? Those services are underfunded, and it's all underfunded at the moment. Whether or not there is a prejudice, I don't know. there may be, there may not be. I'm not sure. I think it would certainly be fair to say that some people may be surprised that, for example, substance misuse services prescribe kind of drugs to people that are an alternative to kind of heroin use, and that's an interesting concept, isn't it? Prescribing something that is in itself potentially addictive or has a similar effect, and that might be a surprise to some people. But I don't know is the answer. I don't know whether there's a prejudice there or not. I wonder if colleagues who work in substance misuse might have a better view of that. But yeah, it'd be certainly fair to say that the services are underfunded, I would say.
I think, can I just come in there? I mean, there's
course,
quite a lot of work that has been done by the Home Office and as well as the Office of National Statistics. So currently, I mean, the funding, for treatment and prevention of addiction in England and Wales, it's about 600, 700 million pounds every year. However, if you consider that the cost to the society of illegal drugs is around 20 billion pounds per year. Now that is about 1% of the GDP of United Kingdom. It is massive, and there is so much sort of unmet needs. A lot of the treatment services are disappearing, and the treatment workforce is declining as well, by number as well as quality. And this is something that, as a society, that we really need to, have a think, like Ed said, moving away from blame and actually considering it as a disease. I think we know that, health and social care is under so much financial constraint. The question really, if you're on the commissioning board and you've got £1 billion to spend, would you be spending the money looking at solving problems related to drug addiction, or would you be supporting people with cancer? So balancing that, I think has always been a problem for policymakers and social economists who work in the Department of Health and Social Care. So it's a difficult one. I guess maybe people on the call might have different views to it. It's a very difficult question to answer.
Oh, we've had some views that have come in just as you've been speaking there, Azuma. We've got well said, Edmund. More focus on understanding the nature of addiction rather than the often negative views, misconceptions, stigma, and ignorance of some. Addiction is not a simple matter of choice, but lots of different factors. And then someone else has said, I have to say, personally, I view addiction as an illness and would agree with you. However, the perception of substance misuse changes according to the social class. It tends to be glamorized in the wealthy few, whereas it is frowned upon in the ordinary working folk. And we also had a spam bot that tried to join in the conversation. I don't know if anyone spotted that. A spam bot appeared, apparently. And then we've got, I feel there's a real disparity in how addiction is viewed. So we've talked about addiction so far in quite a kind of wide-ranging theoretical way, I suppose. To bring Mohammad into the conversation, Mohammad, can you tell us a little bit about some of the most common drugs that you're coming across in your lab?
Yeah, sure. So on day-to-day basis, when we analyze the post-mortem samples or substance misuse samples received from our service users across the country, when we analyze them, we commonly see opiates, cocaine, benzodiazepines, and heroin, and many other, like commonly methamphetamines, and yeah, these are the most commonly seen compounds, and yeah, these are the most common behind any post-mortem cases or like the deaths taking place in the UK in drug addicting community. So yeah.
And are there any kind of particular trends? Do you tend to get peaks and troughs at certain times of the year? Are there some drugs that used to be a lot more prevalent and are now fading while kind of other ones come through?
Recently, I was reading the article about the nationwide, between the countries actually, on a global scale, which countries have more prevalent abuse of a particular substance. And UK was coming up with cocaine in a particular. So cocaine is mostly abused. I might be wrong. It keeps changing the trend day-to-day basis, but in general, cocaine was one of the most prevalent drug being abused in the UK, and one of the most common drug behind the deaths that was taking place. And we have noticed that in our interpreting our results, analytical results, when we submit them to Ed, who is a consultant toxicologist, that he might be agree with me, but yeah, cocaine and its metabolites are the most common ones on our list.
What one, Sasha, also just to kind of back to one element of the question I was asking then, of do you see a seasonality in substance abuse? Are there parts of the year where you carry out more testing?
It's very difficult to say that, because each case that we investigate is different from another case. So, for example, in routine chemistry lab, when you analyze a sample for potassium, you are expecting, like what sort of reference range you are expecting the results. But in this investigation in toxicology, you can't tell what to expect, because it might be a novel compound as well, which you might not have heard before, and it's the first time that a deceased person has taken or consumed that drug, and that might be the reason behind his death. So yeah, I would pass it on to Ed, who has more knowledge and who is more expert on this subject. But yeah, this is what I know at my level. Yeah.
No, I think what you said is true, Mo. Definitely cocaine. I mean, so THC, cannabis, would be the most commonly used illicit drug in the UK, but THC is not particularly seriously toxic in most cases. The most so cocaine comes behind THC as being the next most commonly abused drug. Of course, caffeine is the most used drug in the UK. But yes, so, and we do see a bit of seasonality. So, for example, we've just come through the summer season, we've just come through the festival season. So we do see more use of things like MDMA, so that's ecstasy, in the summer season when people are at festivals. And sadly, we would see at least one death each year of somebody who's used MDMA at a festival somewhere like Leeds or somewhere like that. So there is that element of seasonality there in terms of those kind of party drugs. But Mo's absolutely right in saying that what's being used and abused differs massively from country to country, and also from region to region. So we do work right across the country for different parts of the country, and we do see it, regional variations and regional differences. So it broadly speaking, it would be true to say that the commonly known drugs of abuse, things like cocaine and heroin, are the things that we see the most of. But we do also see the emergence of lots of new interesting compounds that come up from time to time, and that's the real challenge for us in understanding what those compounds. Well, first of all, in being able to detect those compounds. Second of all, in being able to work out what detecting those compounds means in terms of how toxic they are and whether or not they're likely to cause serious effects. And so, yeah, that's where the real skill comes in terms of what Mo can do in detecting things, and hopefully what I can do in trying to work out what it actually means.
If a new compound has come along and you don't know what it is, can you talk us through a bit of how, from the moment this new compound appears, then knowing what it is and classifying and saying, is this drug that this person has taken? How does that process work?
So when we process the samples for analytical process, we have more than 1,000 compounds on our library. So when we analyze the samples, we do screening of the sample for a large majority of compounds on the library, and then we do confirmation and quantitation. So on screening side, what you asked is for the novel compound or unknown compound which a patient might have used. So what our technique, the way that we use, the analyzer, which will fragmentize the compound, the parent compound, and on basis of the fragmentation ions and its identification and confirmation, software will tell you that as per the analytical records, like this particular substance could be present, and we have a checklist to go through, and then we confirm to say yes, this is the drug behind this, and we try to find the metabolites behind that as well. So altogether, when we write down the reports, which is a draft report, we can confirm like it's a novel compound which has not been taken before, and we have a mass to charge ratio as well. So every single drugs have their own masses, and we gather all these information and we try to put the jigsaw pieces together to work out what novel compound is behind this. And we always we go through the paperwork that we receive from with the samples to establish the fact, like what it could be anything, it could not be most commonly used compounds, but it might be something else. So yeah.
And one thing that you mentioned back then, Ed, was about you might have a person dying of a drug overdose at a festival each year. What kind of percentage of deaths that you're seeing are from someone overdosing on a specific drug, or taking a drug that is maybe not what they believed it was, or that's mixed with other substances?
Yeah, no, that's a really interesting question, and a very pertinent one to the situation in the UK at the moment, in fact. So the percentage is difficult because we see a whole range of different reasons why we might be asked to do a toxicological screen, and it might be as straightforward as this person taking their antidepressant. So that's not necessarily going to be an overdose case, but I would say about a third of the cases that we see are in people who have overdosed or used too much of a substance, or have just succumbed to kind of chronic use of a substance. So if I could use an example, a really good example would be heroin. And we have people who access the substance misuse services who are, in their 60s and even 70s, who have been using heroin for most of their lives. And you could argue have used it relatively successfully, because whilst it's no doubt had a very detrimental impact upon their life, it hasn't killed them. They've been very careful about the amount they've used, and that clearly they've got a very good supplier of heroin, so they know that what they're taking is heroin. But what we've seen more recently, and we see this from time to time, actually, it occurred a few years ago, and it's occurring again now, is that when supplies of heroin are limited, and since the Taliban took over Afghanistan, the supplies of heroin coming out of Afghanistan have been limited. What dealers tend to turn to is to kind of enhance their heroin with other compounds that are going to have similar effects, and that can be kind of synthesized naturally, or that they can get hold of on the internet or whatever. And at the moment, what we're seeing is a lot of heroin is being spiked with compounds called nitazines, which are incredibly potent compounds. anywhere between 10, 100, or even 1,000 times more potent than heroin.
Wow.
And so people who are buying what they think is heroin are actually buying something that is incredibly potent and far more toxic than heroin itself. And that's often when people overdose, and that's often when people die as a result of using heroin or a similar compound, when they don't know that what they're taking is actually a lot more potent and a lot more toxic than they think it is. And that's a really good example of how we have to kind of react very quickly to emerging trends in the UK. To first of all be able to detect these things, to understand how toxic they are, and to try and work with the coroner and the police and the various services to flag up to individuals that these very dangerous compounds are available and that they might be in their heroin source, and to be careful, essentially. So yeah, that's just an example of something that's happening right now in the UK and is really causing a lot of concern, actually.
No, that's a really good, that's a great example. And before I take it back to Azuma to talk about kind of general lab equipment and the kind of team in the lab and the equipment you use, is there a kind of a chain reaction from when you might have a particularly bad case that comes in and there are societal concerns where you speak to someone, they speak, and it gets out to the police so that they can get the message out? Are those kind of protocols, and are they in place, Ed?
Yeah, absolutely. So often we won't necessarily be the first ones to detect something. Often it will be the people who are testing things from seizures from customs and excise, who will seize what they think is heroin, and then it will often go off to a laboratory who will test it to see if it truly is, and they might feed down information to laboratories to say, look, we found this coming into the UK, look out for it, and then we will endeavour to look out for it, and then that will all get fed back to the coroner and to the police, who will all work together to disseminate the information across the country, and ultimately to substance misuse services and to the police, who can then kind of liaise with their local populations of users and try to inform them of the dangers of what might be going on. So yeah, I wouldn't say it's a perfectly organized or necessarily a completely smooth process, but there is a process there which involves dissemination of information to all the different bodies, so that they can act in hopefully the most helpful way to kind of warn those who might be most at risk from these compounds.
Great, thank you, Ed. And to go back to Azuma, we've had a question come in. I was about to ask you about the lab and the equipment Azuma, and this kind of links in. A question. Here we go. I missed the start, but I was wondering what part point-of-care testing could play. Would there be scope for monitoring, e.g., patient monitoring in patients to help prevent overdoses, almost akin to safe injection sites?
Right.
Does point-of-care testing have a place in toxicology, do you think, Azuma?
Yes, it does. But generally, if I can start with, elaborating, the role the laboratory plays in drug of abuse management, as well as drug testing. So there are, different scenarios in which, the lab, comes in. As we know, the management of drugs for use, patients is a multidisciplinary, affair, and you've got the doctors, you've got the nurses, you've got the psychologists, and then you've got the lab as well. So generally, we can be involved in workplace screening, in certain professions, where they've got a zero policy, to taking drugs. We can be involved in ensuring that the employees are drug free. So they send samples to labs, and then we can monitor the and screen their samples, blood and urine, for drugs. We also get involved in therapy monitoring. I'm sure you heard mention that previously. So we do have pregnant women, who are sort of known, addicts. So they've got to come to substance misuse in centers and clinics, and they're monitored all through their pregnancy. And also prison services. As we know, there is a very high level of, drug taking in prisons, currently in England and Wales. So labs are also involved in drug testing for prison inmates. And then one of the consequences of, drug addiction is mortality. So when these individuals die and, the death is suspicious, their bodies get referred to the coroner. And then, we get involved because the samples get sent to us and we have to, do a lot of testing to try and figure out, what may have, if drug is involved in the death of this individual. So in the lab,
what percentage of your work is that, Azuma? Sorry.
So that we've got both coronial and forensic. So coronial, it's where the question is asked, is drug involved? So the bit about forensic is the criminality behind it, which has a level, a higher level of proof. So it's sort of different standards of testing. So generally, in the lab, when it as far as drug testing is concerned, so we've got the screening and confirmatory test. Now, I heard somebody talk about drugs, sort of points of care, involvement of points of care, testing instruments in drugs analysis. And in some hospitals, they've got POCT, test kits in their A&Es. As you know, every Friday, Saturday night, people go out to drink, and then, there's usually a number of people that get taken to A&E because of drug overdose. So there are points of care instruments that are usually, deployed in this A&E, centers, to measure the levels of some of the common drugs. So yes, POCT does play a role in drugs analysis. So generally, in a lot of labs, the screening methods that are employed in most drugs abuse analysis are, immunoassay methods. And then, after that, you've got to confirm it. There's quite a wide variety, of confirmatory techniques, depending on the nature of the drug. So some of the technologies that you might find, in toxicology labs, might be, gas chromatography, mass spectrometry, that's GCMS. Then you've got the LCMS, and then the different, sort of versions of LCMS. You've also got the high resolution mass spectrometer, which we've got two of those. So the whole idea is to screen and then quantify, the level of these drugs in order to either guide treatment if it is just, for, therapy monitoring, or maybe if it is for coronial analysis, to give you an idea of the level or amount of drug, that this disease may have had, in order to help us, write a report, to either confirm, that, that particular drug was in their body, at the point of death. So yes, there are challenges, for each of these methods, but one thing, it's important for a given lab, a toxicology lab, to run very well. We've got, a different, professions and professionals, that, work in a toxicology service, right from the medical laboratory assistants that receive the samples and book them in. We've got associate practitioners as well. And then we've got biomedical scientists of different grades that are involved in the analysis and reading of the reports. And then our clinical scientists, that, interpret and write the reports. And in Sheffield, we also do have a medical officer, that assists in the reporting. So we are a multidisciplinary, team, working in toxicology. And that's actually why I think that we do have one of the most fantastic, team of, toxicology, personnel in the country.
Brilliant. We've had a question coming on Twitter that links in quite nicely with what you were just saying there, Azuma, which is how long does routine testing take to carry out, and what samples are prioritised for testing?
Right, routine testing. You mean like routine toxicology testing?
I guess there might not be such a thing as a routine toxicology test, but if you talk us through some of the more typical tests, how long do they take to carry out, and are there specific samples that you prioritise?
Right. So in our toxicology lab, like most other labs, we do receive, bloods, urine. We receive, cerebrospinal fluid. We receive, tissues, gastric content, and a wide range of other, body fluids and tissues. So currently, for us, like when we're doing drugs review testing with urine, using the immunoassay technique, you would expect, results in a day. But when you move on to the confirmatory testing, with where you use the more high tech, cutting edge technologies, that involve extraction, and then putting on the equipment that runs overnight, and then takes some days for the reading to take place, and then for the reading to then be reported. So on the average, you should expect to get a result if it is like a comprehensive testing. You're looking about 3 to 5 days. Because we have to ensure that these samples are rigorously tested, and that all the checks are sort of certified before we have them reported. And obviously those reports have got to be peer reviewed by the clinical team before they are released. So toxicology testing is very complex, and that is why it requires years of training. And one of the problems we have at the moment is actually recruitment. Trying to recruit and retain highly experienced members of staff. So I think that is something that every toxicology service in the country will attest to. Because of the complexity that is involved in the interpretation. So that's what I've got to say on that.
Brilliant. And either Mohammad or Ed, whichever one of you feels best placed to answer this, there's, as Azuma was saying, it's an incredibly complex, ever-changing field, and with no one batch of drugs being exactly the same, and constant different formations and formulas and kind of different combinations of drugs, is it very hard to keep up with what's happening out there? Are you kind of constantly chasing?
Yes, is the simple answer to that. I think possibly 20 years ago, it was fairly straightforward in terms of people would use cocaine, or they'd use heroin, or they would use an amphetamine. You wouldn't usually use lots of different things in lots of different combinations, and a relatively small panel of different substances, well-known substances, would be fine to detect everything that people were using. But what we've had in the last 5 to 10 years is like an explosion, essentially, of new compounds that are being made available to people. You could go on the internet, and if you knew what you were doing, you could quite easily purchase anything you wanted, really. And you wouldn't necessarily know that what you're purchasing is the thing that you think it is, but Often it will be, and there's factories across the world that would produce these things for you. So keeping abreast of those trends is really difficult, and I guess many people on the call will have heard of the phrase legal highs, which we now refer to as new psychoactive substances, because they've now been made illegal by the government. they're not legal anymore. But this is just where people who are selling drugs are altering the structure of drugs ever so slightly. So most up until the emergence of legal highs, most drugs were defined as being illegal based upon their chemical structure. And so if you alter the structure ever so slightly, then that drug no longer becomes illegal. It's legal. So we've had this kind of explosion, really, of all these new compounds that have come onto the market that have very similar properties to the kind of your traditional drugs of abuse, and in many cases much more potent properties, but which are now illegal and do have very significant toxicological consequences for people. And keeping up with that is really, I would say, our biggest challenge, just in terms of, as I say, being able to detect these things, and then also sometimes knowing what it means that somebody's taken a particular compound. Sometimes we're saying, well, this drug has got a very similar structure to heroin, and so we think it's likely to have a similar effect, but it can be sometimes very difficult to pin down exactly what an effect might be, just because we don't have huge amounts of research or literature on some of these compounds that are emerging all of the time.
And with new psychoactive substances now illegal, or legal highs being classed as new psychoactive substances and being made illegal, is there the fear that people will just have to kind of move a few steps further away from the original compound, or is the law broad enough so that there's no danger of someone being like, this is heroin Mark 17, which is a very different thing?
So the new there's the 1974 Control of Substances Bill, which defines drugs based upon their structure, and that's being added to all of the time. But there's also the new Psychoactive Substances Bill, which defines drugs based upon their effect rather than their structure, and that's really kind of a catch-all piece of legislation, which allows for any compound that has an effect on a psychoactive effect on cognition, essentially, to be illegal. And it's got massive caveats with it, because obviously caffeine is a psychoactive substance, and nicotine is, and things like that. So there's lots of kind of exemptions, but as far as I'm aware, it's not been particularly successful in preventing the use of these compounds, or if it has prevented people from, it's prevented people from selling these compounds in head shops on the high street, but people still accessing them in other ways. Or if they're finding that they don't really want to access these compounds anymore, they're just going back to using the traditional stuff like the heroin and the cocaine, because I guess if everything's illegal, then you may as well go back to using the stuff that you know rather than the stuff that you don't know. So I don't think it really had a massive effect on reducing the amount of substance misuse. It maybe just changed a little bit what people are using and move those people around to different things, and maybe made it less easy to buy them on the high street, but it's still, as I said before, easy to get hold of them online if you know where to look.
Just one more thing I wanted to add, what Azuma and Ed mentioned about complexity in toxicology and the challenges we are facing, is that several compounds have similar chemical characteristics. So when we analyze the samples, they come up on our analytical reports with the similar retention time, similar fragmentation, and it's very challenging task to differentiate which compound is actually the deceased person has taken, and we don't take it lightly, like this. It's very complex to come to the conclusion that out of these two compounds, which are exactly having similar characteristics, I'm going with this compound. So it's very challenging task, and that's why it's laborious. And as Azuma mentioned, training our staff members to that level is a key thing to producing accurate and robust results in toxicology.
Brilliant. Thank you so much, Mohammad. We're nearly out of time. I've just got one comment and one message to read out. So the comment, which feel free to respond to if you would like, speakers, is I suppose HPLC and mass spectrometry. I will say this wrong. Spectrometry have made detection of compounds and their variants much easier now. Is that the case?
I'd say that the use of mass spectrometry allows us to react quite quickly to changes and variations. I wouldn't say much easier, but that is definitely the technique of choice, because it's sensitive, it's specific, and yeah, we can use it quite rapidly to look for something that perhaps we hadn't even known that we needed to look for. A few days ago. So yeah, mass spectrometry, particularly accurate mass spectrometry, high resolution mass spectrometry, is the tool of choice and is a really vital instrument in allowing us to be able to detect all of these compounds.
That's great. And a final message from Deborah, our IBMS president, who is listening tonight. Hello, Deborah. She says, "Evening all, love listening, and thanks to our fabulous speakers this evening for their wealth of knowledge and sharing their insights. Remember, if you want to learn more, hashtag IBMS Congress 2023 has the toxicology program running on Thursday, the 28th of September. So, yeah, if anyone is going up to Birmingham, can make it up to Birmingham, there's a fascinating toxicology program on the Thursday. So yeah, have a look online. The whole program's up there, and yeah, I'm sure you'll find some amazing things there. And yeah, just to echo Deborah's thank you. Thank you so much to Azuma, Mohammad, and Ed for joining us today, and for everyone who's joined in to listen. There's been some fascinating insights, and thank you for your time. It's really appreciated. And if anyone's got a question that pops into their head after this, or if it can be a bit tricky multitasking, trying to look through the Twitter messages to respond to everyone. So if there were any questions that were missed, or questions that you want to ask that you didn't have time to ask, then just send me a message on Twitter, and I will make sure that those questions get answered and get to the right people. Also, finally, if you're listening and you think, I wish they would cover this on one of these Twitter spaces, then let us know. We're doing it for the members. So if there are specific things you want covered, then just message the IBMS, message me, let me know, and we will do what we can. Yeah, Mohammad, Azuma, and Ed, thank you so much. Is there anything you would like to say before we head off, or should we say goodnight?
Thank everybody. It's been a wonderful experience. Just sharing now.
It's been a pleasure to attend this event. It's nice to have this chat. Yeah, thank you very much, everybody.
Yeah, as well, if you've got questions, just feel free to let us know. We'll be happy to answer them.
Brilliant. Thank you so much, everyone. And we will make this recording. It will go up on the Twitter feed, so people who couldn't make it tonight can listen to it. So if you've got any friends who you think should have been here and couldn't make it, then keep an eye out for it on the Twitter feed and let them know. And thank you again, everyone, for coming along, and good night.
Thank you so much for listening. I hope you enjoyed the episode. If you did, then why not join us live at 8 p.m. on the first Wednesday of every month, where you can listen to the conversation and even join in by posting questions. Just keep an eye on the IBMS Twitter feed at that time and date, and click on the link to join the conversation. Alternatively, keep an eye out here for further podcasts. Thanks for listening, and remember that these episodes can be used for your CPD.